Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we're continuing our current series which focuses on our risks around prescribing. And today we're looking at standing orders. So my name is Lucy Gibbard, and with me today I have my colleagues and fellow GPs and MPS advisors Sam King and recent retired Tim Cookson. Hi Sam and Tim.
Hi Lucy.
Hi Lucy.
And once again we also have Kate Wills from our panel law firm Wootton Kearney to help us with the legal aspect. So thanks for coming, Kate.
Hi Lucy.
Okay. So in our previous podcast we were talking about when a doctor writes a script for a specific patient at the request of a different health practitioner. But now we're going to go on to look at standing orders. And we have actually done part of a podcast about this before, but I think when we're looking at prescribing, standing orders create some specific obligations. So I think it's a useful thing for us to look at. Because it often comes up on our advice line calls. And over the past few months, we've had some rather specific scenarios that have been highlighted to us. So I thought it would be helpful to have another look at them. So before we turn to those specific scenarios, Sam, can you just give us a quick overview of standing orders and how they work? Because I think we all kind of know the word, but we often kind of gloss over it and just assume we all know what we're talking about. But so
Yeah, no
clarify
problem,
it for us.
Lucy. There is on the Ministry of Health website, there's the guidance is posted up there and it's very detailed, which must be followed. So if any of you would like a more detailed description, I'd suggest you go there. But a standing order is a written instruction issued by a medical practitioner, dentist, nurse practitioner or optometrist. It authorises a specified person or class of people, for example, paramedics or registered nurses, who do not have prescribing rights to administer and or supply specified medications and some controlled drugs. It does not allow for a script to be generated, just for medication to be prescribed and supplied directly to the patient. So it is not a blank pre-signed prescription, nor is it a script generated with no doctor's signature. So that in general is what a standing order is.
Yeah, and I think it's often looked at as a script that is done and the patient gets a prescription. But in fact, for a standing order, the patient cannot get a prescription. They've actually got to be given the medication. So just to be clear, who can provide medicines under a standing order, Kate?
A person who is allowed to administer or supply medicines under a standing order must be engaged in the delivery of a health service. For example, nurses, paramedics, but there is also nothing to say that they have to be a registered health practitioner. It could also be a healthcare assistant or a health coach. While there's no need for the person working under a standing order to have any particular qualification, they must have the competency and training to be able to make an assessment that the standing order applies to the presenting patient, the competency to administer and or supply the medicine, and the knowledge to assess the contraindications and or exclusions.
So it doesn't have to be a nurse. It doesn't have to be even a registered health practitioner, but it has to be someone who's engaged in a health service.
Mm-hmm.
That's right. And obviously who's been trained up to identify and meet the requirements to ensure it's safe.
That's interesting because we were asked at one stage about workers in a factory who were training in first aid and whether they could give medication under a standing order. And the opinion was that they can't because they weren't, quote, engaged in the delivery of the health service. So although they were training as first aid, that wasn't their primary role, I presume, and therefore that's why it was felt that wouldn't apply to them.
So can any medication be specified in a standing order? Can we write controlled drugs? Can we write unapproved medications or medications that are being used for unapproved uses? Does it matter what medication we write on it? Is it?
You can issue a standing order for prescription medicines, pharmacy only and pharmacist only medicines, and most controlled drugs. There are some carve-outs, and they're specified in the Ministry of Health's standing order guidelines, which Sam mentioned before, are quite comprehensive but also useful to look at if you have any questions about these standing orders. The situation's a bit more complex in respect of unapproved medicines and unapproved use of approved medicines, and I think we might be covering this off later on.
Okay, that's good. So we'll leave that.
Leave
for a
the
bit.
hard bits.
Leave
for
the
later.
hard bit for later. Okay. So Tim, what are the obligations of a doctor who is issuing a standing order? The person who's actually writing it for others to use.
Well, obviously, the first thing to do is to look at the ministry website and look at the requirements, because they all do need to be met. But one of the important then caveats below that is that the doctor who's issuing the standing order has to ensure that anyone who's operating under that standing order, so any health practitioner who's going to be actually dispensing the medication, has had the appropriate training and competency. And so, that's easy in a general practice setting where you practice nurses and things, but you can envisage situations where the contact is a bit more remote, and that may put different kind of pressures on the doctor who's issuing the standing order to really be assured that the person who's delivering the medication has the appropriate competency. And then there are some requirements around audit, countersigning, and reviewing the orders on a regular basis that need to be complied with as well.
So when you sign a standing order, all those obligations actually land on the doctor's shoulder rather than their employer. So if the employer is saying, look, can you sign some standing orders for the 36 nurses we've got working in our outlying clinics, and you do that, actually it's not your employer that's going to be responsible to make sure that they're competent and trained and everything else. It's actually the doctor whose signature's on the standing order is going to be entirely responsible for that. Is that right?
As I read it, yes.
I mean, that's quite a significant obligation, especially if they are in outlying clinics and you don't actually work directly with them, as you say. And it also means that the doctor has to actually check the notes and countersign every time a standing order is used, or do the monthly audits, which is what's required in the regulations. And I understand that MedSafe have actually clarified that it has to be the doctor who does the audit. You can't delegate the audit to somebody else to do it for you, which means if you've got a whole pile of people working under standing orders for you, either you're doing an awful lot of checking the notes and countersigning, because the countersigning does revolve, you have to check the notes, or you're doing an awful lot of auditing yourself because you can't get somebody else to do it for you.
And I suppose that the risks involved in standing orders are going to depend on the complexity of the scenarios that are involved, and also the potential seriousness or risk of side effects of the medications that are being prescribed. So, one of the common ones, of course, is treatment of UTI in a general practice, and provided you've sorted out a checklist and whoever's going to be dispensing the medication has gone through the checklist, tick the boxes, then, you can be reasonably assured that, you don't have to look at the practicing certificate of every single one of the 36 nurses. You can be reasonably assured that they're able to do that. But if you're, for example, the standing order is for Botox, that's going to be a completely different scenario in terms of assuring competency.
I think that's the key, isn't it? Is that it really depends on the medication that you've signed the order for as to the lengths you will need to go to assure yourself about competence.
And that competency has got to be, if it's not set by a registration authority, it's essentially the issuer's got to be assured of it in some other way.
And if you think about Botox, obviously you need specific training to be able to use it and to know when to use it and the side effects and how to deal with them and all that sort of stuff. It's not a simple assessment, I don't think.
No.
So I think that, for those clinicians who are involved in appearance medicine, there are some very specific things that you need to consider. And I know that, you, Lucy, have had some interactions with the local clinicians around that.
And we are going to come up talking about that because it becomes, it's part of the unapproved use of an approved medication. So we will talk about that. But the actual first call that I was going to talk about was actually one around pharmacists providing patients with GLP-1 agonists, Wegovy, using a standing order. So this is a pharmacy chain in New Zealand who are advertising that patients can come to the pharmacy, get this medication without seeing a doctor to get a script. And the pharmacists are providing the medication under a standing order. So, Tim, do you think this lies within the intention of standing orders? Because the intention of standing orders was to increase patients' access to medication for the public. You know, it was for times when you couldn't get a doctor, and actually that's a good way of getting patients access to care if there's no doctor available. Do you think in this situation where Wegovy, weight loss medication, is being provided by a pharmacist without a doctor being involved, is that the intention of it?
Well, my first thoughts were no, not at all, because first of all, it's a relatively new medication, so it's not all the side effects may not be known. It's complicated also as a medication, and most standing orders are for single one-off episodes as opposed to something that's going to be needed to be continued. But then I thought, well, maybe, in family planning, for example, I know there are standing orders for nurses to prescribe contraceptives 6 months at a time. That's a long-standing thing. So, maybe there's a justification, but I would have thought that the risks for although yes, if you really stretch it, it could come under the, what standing orders were set up for. But my personal view is that the doctor who's signing that standing order has got a hell of a lot of work to do to make sure that they're safe and not vulnerable.
I think the question I would ask is, did they envisage that complicated medications would be used under standing orders, or was in their mind they were thinking, it's only ever going to be paracetamol and ibuprofen, and simple things, obviously no one ever. Wegovy wasn't even around, so was that even in their thinking? And to be honest, I would have said it wasn't. And if you think about the weight loss and the approach to that, it involves a lot more than just prescribing Wegovy or giving Wegovy, right? It involves a lot of counselling, monitoring, all of the rest of it, and talking about other options. And so I think that for a doctor to sign a standing order for this, it requires them to be sure of the training of the pharmacists who are working under that standing order, and that's quite a big workload. And it might be that some doctors who run their own clinic, they've got their own nurses or pharmacists or whomever, and they're prepared to do that. But it's a lot of work.
And there is some issue with that whole fragmentation of care thing, that if you've got a patient, it's almost like the single use clinics, where if you're only looking at that little bit of the patient, if that same patient had gone to get a script from a doctor, they may have actually, it was their regular GP, they may have actually had other underlying health conditions recognised and treated at the same time. So, I think I'm not sure it is what was intended by standing orders. And clearly there are risks. So, Sam, what about the doctor who's issuing the standing order? What is the risk to them?
Well, it's the same as signing any prescription. We take responsibility ultimately for what happens. I think that if you have for example, a nurse who is operating under a standing order, and you've checked them off and ensured that they're competent, they understand, and they do all of those sorts of things, but the nurse themselves makes a clinical error, then I think that the doctor wouldn't be held accountable for that. I don't know if you can step in here, Kate, but that would be my view. Whereas what the doctor would be scrutinised as to, how did you ascertain that the nurse was competent? Can you demonstrate that you've got the documentation to say that yes, it was signed off, that you checked that you did some audits, and so that the doctor has done everything that they needed to do to ensure the patient was safe. So I think there is liability. I don't think it's absolute that if an error happens that you'll be held accountable, but it probably does, if that makes sense. I don't know, Kate.
Yeah, no, I would agree with you, Sam, and hope that would be the outcome. The thing is, good practitioners can make mistakes, right? So as long as that doctor, as you said, can prove that they've taken reasonable steps and their reliance on the competency of that person was appropriate, then I think it would be very unfair for them to be then held accountable for a almost unrelated error or mistake, not linked generally to the person's competence.
Except if they've then countersigned rather than audited. At the time of countersigning, they should have checked the notes, and if it was evident from the notes that something had been missed, they would have been expected to check that at the time that they were countersigning, wouldn't they?
I would expect they would, if there was a way for them to detect.
A bit different if it wasn't. They were using the audit option of the monthly audits, where maybe that was one of the sets of notes that didn't get looked at. But I think if they were actually countersigning, I mean, the other issue, Tim, is this issue about whether there's a conflict with the pharmacy making the decision to provide the medication and then also dispensing it. What do you think about that?
You'd have to say there's a pretty strong incentive for pharmacists to think that Wegovy would be a really good idea for this particular patient because I imagine the markup will be sufficient to make it worth their while. And so they'll have a real commercial impetus, if you like, to dispense as much as possible. And that could influence them in terms of making decisions that are not actually, in the end, that safe for the patient because of that commercial kind of push. So, that's a pressure that could end up in some difficulties.
I mean, I think it's interesting that the legislation, our current legislation, has maintained a commercial separation between doctors and pharmacists. Doctors aren't allowed to be owners of pharmacies. But here, the pharmacist is essentially taking over the prescriber role, and we've lost that commercial separation because they're essentially, by the standing order, becoming the prescriber, but also the dispenser, which surely is against what the legislation suggests about medical practitioners and pharmacists not having commercial separation.
Though in theory, the doctor who signed the standing order actually has a significant responsibility here, doesn't they? So that doctor needs to have audited all of the dispensing of Wegovy, and if there are people being dispensed it by pharmacists where the conditions are not met, then you'd expect that doctor to be taking some action. So that might be a counterweight, if you like, to the commercial pressures to dispense, but it's going to depend on how assiduous that doctor is in auditing and responding appropriately.
I think that, let's just say, and I don't know if there is any clinic in existence like this, but you've got a doctor who wants to become more specialised in weight management, and they're the ones who perhaps own a business and they've delegated the consultations to the pharmacists. Clearly there's a conflict of interest there, but that doesn't mean that the doctor doesn't still have absolutely the same responsibilities. But there are lots of clinics who, they're not using a pharmacy, but they are consulting and selling the product to patients. Of course, there's a conflict of interest. I guess the responsibility lies to ensure that you've got clear rationale for your prescribing and that you're doing it appropriately. And I expect that there would be strong criticism if it's been found that you're not acting in a patient's best interests.
Yeah, exactly. I would agree with that. And you can be commercially invested, but alongside that, you've got your professional obligations to act ethically and prioritise the patient's best interests and those sorts of things. So that acts as a sort of safeguard, and certainly you'd be at big risk if you prioritised your commercial interests over your professional obligation to make sure you're providing appropriate, targeted, effective care.
There is actually a medical council statement on doctors' obligations in
Yes.
commercial organisations, isn't it? So maybe that would be covered by that. And interestingly, I think the government are actually looking at the rules, because at the moment I think pharmacies have to be owned 51% by pharmacists, don't they? And I think they're actually looking at the rules about whether they're going to stick with that. So it's obviously something that might change in the future. Maybe a watch this space issue. So the next scenario I wanted to briefly touch on is one that Kate was looking into for us. I thought it would be an interesting one to talk to her about, with regard to standing orders for unapproved medications or for approved medications that are being used for an unapproved use. And I think Botox is the example that we were asked about here, where the MedSafe approved uses are limited, where in fact by medical practice it is often used beyond those licensed indications in many cases. So Kate, can you just briefly explain where we're at with our advice on this and what's happened?
Sure, yes. I'll start with the easier point, which is whether unapproved medicines can be administered or supplied pursuant to a standing order. So that's slightly different from the Botox question, because the Botox is an approved medication, but as I understand it, commonly in a cosmetic setting is used for unapproved uses. So we'll get to that more tricky question in a bit, but unapproved medicines refers to a medicine that has not received ministerial consent via MedSafe. And there are exemptions in the Medicines Act, sections 25 and 29, that allow for unapproved medicines to be supplied. These exemptions, however, only apply to particular and known patients or patients currently under that medical practitioner's care. So patients receiving medications under a standing order would not meet this requirement because they're not necessarily known at the point that standing order is sort of signed off by the doctor. So a doctor cannot make a standing order for an unapproved medicine. Unapproved use of approved medicines is a bit more sort of opaque. Using the meaning of this is using an approved medicine in a way that falls outside of the ministerial consent that has been granted by MedSafe. So it's using an approved medication for a different indication or at a different dose. Applying this to Botox, as I understand it, the approved use is just limited to the lines between the eyebrows.
I think it's actually just got a bit broader, but it's just not all the uses at the moment. Yeah.
But I believe in practice, obviously, it goes a bit wider to the sort of crow's feet and frown lines and those sorts of things. So where there is a question about the sort of point of that is, I guess, surely if it's approved to do between the eyes, what difference does it make if it's 3 centimetres up? Is it that much more complex? Is it that much more risk to a patient that requires sort of additional safeguards? So I think that's the question. In our view, looking at the Medicines Act, and I must say sort of at the outset, this is a very old, clunky, complex, difficult piece of legislation to get your head around. And in light of that, there is sort of nothing explicit in the Act itself, nor in the Medicines Standing Order regulations or in any other guidance that prohibits a standing order to use an approved medicine for an unapproved use. Section 25, that exemption clause on its terms is not specific to approved or unapproved medicines, nor does it mention approved or unapproved uses. So we're sort of having to sort of interpret based on nothing explicit what is required of or expected or allowed. In undertaking this sort of interpretation exercise, we have actually come to a different view than MedSafe. So where we see there's nothing explicit saying you can't issue a standing order for an unapproved use of an approved medication, MedSafe disagrees. They consider unapproved use of approved medicine is only permissible if the terms of that Section 25 exemption are satisfied. and that exemption that requires a particular identifiable patient, and so therefore would preclude the supply of unapproved uses of approved medicines pursuant to standing orders. Yeah. So it's a bit of a tricky situation where there are questions about the correct interpretation, but being practical, MedSafe is the regulator, and if they perceive something to be a certain way, there would be a risk to our to practitioners and to go the other way, even if there might be good arguments about ambiguity in the legislation. So, the advice probably would be adhere to what MedSafe is saying, and actually it's a bit risky to apply, sort of utilise unapproved medicines, approved medicines for an unapproved use on a standing order.
I think we'll have lost our listeners. It's really
just so
complicated, isn't it?
Exactly. And I guess even if MedSafe is wrong and I'm sure, you're probably all familiar with the fact that when you're consenting a patient for a medication that's for an unapproved use, there's quite an onerous informed consent discussion that has to take place around that. So we've just been talking about sort of the risks and safeguards and difficulties that doctors face in delegating these consenting discussion tasks to whoever's supplying under the standing order. Those sort of delegated tasks become even more complex if we're dealing with unapproved use. And so even if it's allowed, still very risky and possibly impossible to satisfy the requirements around it.
So we basically come down to the advice being stick to approved medications for approved uses if you're going to write a standing order.
I think that would be the safest, even though that seems to have rather significant consequences, for example, in the cosmetic medicine space where it's common practice, as I understand that, there's sort of unapproved use of Botox. That's commonplace and largely without risk. But, if it comes before the council.
And I think it is one of the problems that the standing order regulations are very specific about the obligations, and that those obligations lie not with the clinic, they lie with the doctor that signed the standing order, the individual doctor that signed the standing order. And so I think that does put doctors at risk. And I don't know if people often think about what the consequences might be if something went wrong with a standing order where somebody supplied a medication that you wrote the standing order for, even though you never saw the patient. And I think we actually have had an HDC case where exactly that came up, and it was commented by the HDC that no, the doctor is the issuer of the standing order and has a responsibility here to make sure the standing order is being properly adhered to and used, and that, therefore they were responsible. So it's one of those situations that is a potentially risky one for our members. Okay, so we've covered a lot today, and that stuff about standing orders and approved medications and unapproved uses and all the rest is all a little bit confusing. But look, we have been talking about generalities, but I think it's really important if you have a specific issue or concern about a standing order that you've been asked to issue or any other scripts that you've been asked to write, and you're an MPS member, please do just call us on our advice line, which is 0800 2255 677. Option 3, and ask to talk to the on-call advisors. And you might get Sam and you might get me. And
we might just put you through to Kate.
Oh, we might just put you through to Kate. And hopefully we'll be able to ask your specific questions, because this can be a fraught area. And if you're not sure, much better to ask. So thank you for listening to this podcast. I hope it's been helpful. And thank you to Tim and Sam and Kate for joining me. We look forward to catching up with you in our next podcast. And if you like the Medical Protection Podcast, please subscribe and leave a review. If you'd like a podcast on a specific topic, please email nzpodcast@medicalprotection.org.